hazards that is all the labor workers are feeling, and you have done an excellent research work on it. May all the participants must got benefited by it. Hope all the best. And anyone would you like to ask any question? You are most welcome. Anyone? Thank you, Doctor. I'll ask and now start with the next session. But I'd like to invite Dr. Soumyadarshan Nayak from MKCG Medical College, India, to present as a research work on the clinical characteristic and management of the headache, a real-life prospective observational study from a Tertiary Care Center in Eastern India. Dr. Soumyadarshan, please.
Thank you, ma'am. Thank you for giving me. Am I audible?
Yeah. Your slides are visible and you're also very clearly audible. You can proceed with your session.
Thank you, ma'am. Thank you for giving me this wonderful platform of Otorhinolaryngology and ENT Conference 2023. Basically, I'm a headache specialist and a neurologist. And what I would like to present in this August conference is our study on headache. Basically, this is an observational study which we did at our institute over a 2 years period. And the goal of our study was to get data from Eastern India, because Eastern India is very less represented in most headache studies. And studies from India are also very sparse regarding headache. So with this goal to know what are the various types of headache, how common it is, what are the diagnostic and what are the treatment modalities available to us, we proceeded on this observational study. So this data we published in 2021-22, and this data had a lot of authors. Basically, I want to highlight that in this ENT conference, we have heard dentists, we have heard ENT surgeons. Now, give me some time to present headache as one of the most common reasons which requires medical attention, for which a patient or people seek medical help. Headache occurs in the lifetime of a person at least once a year. And if you ask, 50% people in their lifetime have had a headache at one time or the other. But most people don't go to a doctor to seek help. Most go for over-the-counter drugs from a pharmacist or a chemist. And there is very less chance that a patient seeks the help of a neurologist for headache disorders. Most of the time, they self-diagnose and go to an ENT specialist thinking it's a sinus headache, sometimes to an ophthalmologist thinking of eye power change, and sometimes to an orthopedician thinking it's some neck pain or spondylosis. So these are common misnomers which cause a lot of confusion. Headache disorders are also associated with a lot of morbidity, less of mortality. And if you see, there are two types of headache disorders. 90% are primary headache disorders, while 10% are secondary headache disorders. This is from cephalalgia, and many studies have shown this to be true. the ICHD beta, 3 beta classification provided that headache can be classified as primary, which included migraine, tension type, cluster headache, and sinusitis. And there are other secondary headache disorders like the meningitis group, bleeds, tumors or space occupying lesions, giant cell arteritis, subarachnoid hemorrhage, and some referred pains like from dental, ENT, which mimic as headache disorders. So basically, headache, when we are talking of headache, we are talking of the primary headaches. The most common disorders worldwide are tension type and migraine. What we see is worldwide tension type headache is the most common disorder over Western data, Southeast Asian data. But if we come to India, we see that most studies show there is a prevalence of migraine. Migraine is one of the most common headache disorders with a female preponderance, and the age of occurrence is usually from 2nd to the 5th decade. However, prior to puberty and hormonal changes, migraine prevalence is higher in boys. And there is limited information from our developing countries for which we planned this study. Secondary headaches are very infrequent, but if you see data from hospital-based studies, they show higher prevalence of secondary headache disorders due to referral bias. Cluster headache affects less than 0.1% of the population. And in our study, we plan to describe the clinical profile, the investigation and management pattern, along with the radiology, the triggers, and how the treatment was followed and the prognosis of these patients at 3 and 6 months post-treatment. So what we did was we selected patients more than 14 years of age who presented with headache as the primary complaint. Their demographics and clinical features were recorded on an Excel spreadsheet and also on the computer-generated sheet where we filled up, especially our residents did a lot of work. We did their investigation in-house. Most had a computerized tomography, and some patients went for MRI and MRV. We categorized them into primary, secondary headaches. We noted the etiology and also the triggers. We also noted down what abortive treatment was given for migraine and also what treatment was given for TTH, cluster, and also TAX. We followed them at 3 and 6 months, apart from the baseline values. The disability was assessed in terms of the MIDA score, the visual analog scale, and the headache impact test, HIT-6. So basically, these disability scales are simple scales which you can do on an OPD basis, and you can know whether the patient has a mild, moderate, or severe headache, and on a visual analog scale from 0 to 10, whether there are no symptoms to worse symptoms. And we correlated these scores with their treatment protocols. We took informed consent, and statistical analysis was done as paired t-tests. And for quantitative variables, we used mean and standard deviation. We also used Pearson's correlation A statistical p-value of less than 0.05 was considered as significant. So a total of 400 patients where we had primary headache in 277, that is 69%, almost 70% had primary headache, where secondary headache was 30%. Already I had told you that institutions have this referral bias where more secondary headaches are referred to institutes. It was female preponderant with 60.25% of our patients being females, while only 39.75% were males. If you see the age group, between 21 to 40 years, a majority of our patients, more than 63.5% of our patients belong to this age group. And OPD presentation was 76%, while IPD, 24% required IPD admission. Already I have told you that 69.29% were primary, while the rest were secondary headaches. So what are the associated symptoms in these patients of primary headache? Normally, if you see a migrainer, there are certain triggers which cause the headache to appear. So mostly these associated symptoms are nausea, vomiting, photophonophobia, and there may be some oral symptoms. As you all know that migraine can occur with or without aura. Without aura is the more common method of presentation. Along with headache, there may be associated features. And when aura is present, there may be some visual aura, there may be some conjunctival congestion, lacrimation. These are known as the autonomic features. There may be some neck pain. And along with the associated symptoms, we saw that consumption of alcohol, tobacco, and also some form of betel chewing, smoking, addiction in patients with headache, primary headache. So if you see, the most common symptoms were nausea, vomiting, photophonophobia. And aura was present in only 15.88% of the patients. And conjunctival congestion was present in only 7%. Neck pain in almost 40%. But a lot of these patients, at least 1/3, had history of addiction. So what are the types of headache we observed? In our study, we saw that the oral symptoms were present in only 15.88% of our patients, while 119 patients, that is almost 42.96%, were migraine without aura. Let me tell you, we use the ICD 3-beta classification for definitions of migraine, tension type headache, cluster headache, and TACS, or the trigeminal autonomic cephalalgia group, was only 1.8%, while cluster headache was 1.1% of our. But if you notice, tension type headache was only 38.27%. So the migraine subset was much more than the tension type headache in our study. That is why our study was different from other studies in Southeast Asia and also the Western studies. So these were some of the triggers for migraine. Let me explain. We have the blue and the orange graphs. The blue graph is the migraine with aura. The orange one is the migraine without aura. So if you see that majority of the patients in migraine with aura had stress, inadequate sleep, fatigue, and hunger, along with menstruation, which were the common antecedent triggers. While migraine without aura, if you see, menstruation to some extent, fasting, non-vegetarian food, dehydration, and bright light were the most common triggers in our study. When we started treatment for these patients, we used abortive treatment as well as we used prophylactic treatment. In abortive treatment, we used naproxen, we used ibuprofen, we used paracetamol. These were the NSAIDs we commonly used. We also used triptans in the form of rizatriptan and sumatriptan. We also used tramadol, paracetamol combinations. Some patients had responded to such combinations. For prophylaxis, we used divalproate, we used flunarizine, we used propranolol and topiramate. So after giving treatment, we observed them after 3 months and after 6 months. If you see, the blue ones are the patients presenting with grade 1 on the MIDAS score, and this is grade 2, this is grade 3. This is all after 3 months of treatment. And the orange ones are those after 6 months of treatment. So let's say if a patient presented with grade 4 on the MIDAS score, that is very severe headache, but after treatment of 3 months and 6 months, there was no patient with grade 4 MIDAS. They had downgraded to either grade 3 or grade 2. So this was after 3 months, and after 6 months, the number of patients in grade 3 had downgraded from 64 to 41%. Most of our patients were in grade 1 or grade 2 MIDAS, which was a good achievement in the first 6 months of treatment. Similarly, if we took the VAS score, we saw that those who had presented with severe headache at baseline, the severity had reduced by 3 months and 6 months of prophylactic treatment. So this indicates that if you advise the patients regarding treatment, physical rehabilitation, and other ancillary treatment methods, they are more amenable and they do follow up. So these are some of our radiologic findings in the patients with headache. Majority where the CT scan was performed, 82% were normal. These were cases where we suspected some etiology but did not find any. While MRI was performed in 71 cases, that is 17.75% of the cases. Now, if we see the common abnormalities on CT were SOLs, if you see, intracerebral hemorrhage was found in 5.47% patients, and subarachnoid, which was a common cause of presentation as headache, in 4.25% of the cases, along with subdural hematoma and infarctions forming a meager percentage. At least 5% patients had sinusitis on CT scan. Whereas in MRI, we had CVST, we had subarachnoid hemorrhage, we had IIH and periventricular ischemia, infarct, and meningoencephalitis as the common causes. Most common was CVST, but 30% MRIs were normal, while CT, 82% were normal. These are some of the images, CT and MRI conglomerated of some of our patients. If you see, this is a subarachnoid hemorrhage, this is a CVST, this is a GBM, this is a cyst in the optochiasmatic pathway. This is again a cystic sol picked up on CT. There's a bleed, and these are cystic tumors and periventricular leukomalacias. So these are the findings on CT. The bigger chunk is the normal ones. And among the common findings on MRI, as I already told, CVST and sinusitis. And if we see the results of the 400 patients, I've already told you, 60% were females and 39 were males. 70% were primary headaches compared to other studies which showed that 90%, up to 90% can be primary headaches. And of these, 42% had migraine without aura, which was the most common subset. The most common triggers for migraine were stress, menstruation, fasting, inadequate sleep, and also we found that mobile was also as common, especially screen time more than 6 to 8 hours. Nausea, vomiting, photophonophobia, and neck pain were the most common accompanying symptoms. And tension type was lower, second in the ladder, 38.3%. And disability improved with treatment. I've already told you what we used for abortive as well as prophylactic treatment. And most common causes of secondary headache were intracranial bleeds and cerebral venous sinus thrombosis. Now, coming to the discussion, if we see 40% of our patients were in the age group of 21 to 40 years. So this is the economically viable age group. So they require treatment, counseling, so that they don't run from pillar to post and they control their own headache. Females had a higher ratio. And there are other studies which show that the 3:2 ratio of our study may be higher in other studies, up to 7.4 to 2.6. And among the primary headaches, I've already told you that migraine was the most common headache. 25% of our patients required hospitalization. Those were patients who had secondary headaches and severe migraine or chronic migraine with medication overuse. So already we have discussed the triggers and we have discussed the associated symptoms. There was a significant addiction history, especially tobacco. And if we see, tension type headache was 38.3%, and we classify tension as episodic and chronic. And among the 38.3%, almost 70% were episodic and 31% were chronic tension type headache. Other studies from Southeastern Asia, where the range is from 20 to 40% with female preponderance. The migraine subset, 81% presented with moderate to severe disability, but they improved significantly from baseline at 3 and 6 months of treatment to less than to almost 0 who presented with grade 4, and grade 2 and 3 were less than 20%. So there was a strong positive correlation with the HIT score at 3 and 6 months. So we used a lot of drugs for patient treatment. These included NSAIDs. We also used antiemetics. We used caffeine. We used sumatriptan or the triptans. And for prophylaxis, we used beta blockers, antiepileptics, amitriptyline, and calcium channel blockers. For TTH, we used tricyclic antidepressants, muscle relaxants, and also combinations. Secondary headaches, depending on the headache, treatment was tailored. However, we had one death, and that case was a case of GBM, who presented very late. So already I've discussed the findings, and concluding my talk, The most common etiology of headache in other populations is TTH, but in our study, it was migraine. Identification of secondary headache is very important. It warrants active management, and you should be aware of the red flags that is termed as SNOOP or SNOOP signs. A detailed clinical history, documentation is very important in our resource poor setups, and timely radiologic investigations are important. Do give your due importance to headache disorders because these have severe disability, and treatment and preventives can ameliorate the lifestyle of many young patients. Thank you for your attention. I close my talk and I'm open to questions.
Thank you, Soumyadarshan, sir. Excellent presentation, giving an overview of headache, which is a common symptoms. Almost everyone suffered from every year from this headache, and including the stress has led to a lot of increase in the incidence of the headache. And you have covered almost everything. And I'll request anybody like to ask any question. You are most welcome.
Yeah, thank you. Thank you so much, Soumya sir. This was a detailed and very excellent presentation. And there isn't much to be asked. Just a query that while collecting the data, you mentioned hunger and fasting separately. I would just like to know what were the parameters in deciding hunger and fasting?
Basically, when you have, what we did was, when fasting is when you force yourself with the fasting, especially those patients who do fasting. If you see in our setup, patients have fixed days for fasting. So they do fast on Tuesdays, they do fast on Fridays and Saturdays. So those were the days when their migraine attacks peak, or they have severe attacks. So what we do is we ask them to maintain a headache diary, and we ask them to mark the days when their headache attacks increase in frequency and severity. So these days are correlated to the fasting. And what we had seen was that those patients who presented with migraine without aura, so those subset of patients had increased incidence of fasting. Hunger is when the patient does not force fasting on herself or himself, but due to the delay in taking meals, they are not able to take meals. They develop a headache. They skip meals, or they develop some gap. They take meals after 1 to 2 hours, but inadvertently they develop headache. So it's not a very clean-cut definition, but we went by this definition that those who have a definite day for this fasting, and those who do not actually fast, but they have derangements in taking their meals.
Thank you so much.
Thank you, Dr. Ram, for your question. Yes, ma'am.
Sir, any other question? Anybody would like to ask anything? Thank you, Dr. Soumyadarshan. Excellent. Now we'll go to our next speaker. Okay, welcome, sir. Now we'll go to our next speaker, Dr. Fatin Khorshid. She is from India.